alone, and not those of Vic Canellis Media Group, its parent, affiliates, or stations. VCMG Live is not responsible for any content, information, or opinions expressed. User bears full responsibility for their reliance on such content, information, or opinions.
Amp2.tv presents You and Your Doctor, teaching you to live a longer and healthier life. Proudly sponsored by All County Healthcare, where people are the heart of our business. All County Healthcare is a Medicare certified agency where one call will service all your home care health needs. For more information, call 954-717-7027 or visit our website, allcountyhealthcare.com. Now, let's get informed to living a longer and healthier life. Here is your host for today's show.
Hi, everyone. Welcome to All County Healthcare, You and Your Doctor. I'm Dawn Graubert. I am your host, filling in for Louise Gomez. All County Healthcare is a Medicare certified, state licensed, and ACHC accredited home healthcare agency that provides you with quality services for you or your loved ones. They serve the Tri-County area in South Florida, so if you are listening to us in the South Florida area on True Oldies Florida, you can always give us a call right here at the radio station at 888-994-4995, Studio A, or reach out to All County directly at 954-717-7027. You can ask for Clayton or anyone on the phone. Be more than happy to help you with any of the needs that you have for Medicare or private duty home care. Again, that number is 954-717-7027. And we have the privilege tonight of interviewing a doctor who is located right now in Virginia. His name is Dr. Ayinde Bourne. He is a critical care specialist at Mary Washington Hospital in Fredericksburg, Virginia. So let's bring Dr. Bourne over. Hi,
Hello.
Dr. Bourne. How are you doing?
I'm doing well, and you?
I'm doing great. Thank you so much for taking the time to sit with us on this show.
Oh, anytime.
It's not often that we have a critical care specialist on the show here. I know you're in Virginia and we're in Florida, but the show is heard all over streaming platforms and on True Oldies, and you never know where somebody's going to be. And our condolences to all the family members out in the Virginia, Washington area from last
Thank
night.
you.
Such tragedy. So our hearts and prayers go out to everybody who is affected. I'm sure you're getting the ripple effect where you are located as well.
We're about an hour south of DC, so the ripple effect isn't as significant here, but we do feel for them.
Amazing. So share with us your journey. You went to undergraduate school in Boston College, and now you're a critical care physician, doctor of osteopathy at Mary Washington Hospital. What led you through all of this process?
Well, I'd always liked the healthcare field, and I was very interested in it from a early age. My mom was a nurse. I spent the majority of my time growing up in the hospital. Got home from school, or actually got to the hospital from school, and then when she was finished with her shifts, I would then go home. But essentially went from there to undergrad and Boston, studied there for 4 years, then came back home to Florida, was at Barry University, did a master's there, and then from there went on to medical school in Michigan. I was in Michigan for about 10 years, which included my med school plus residency, and then I worked in upstate Michigan for about probably roughly 2 years, and it was a pretty small hospital, about 65 beds. 6 of that was in ICU, and I enjoyed the patients in the ICU there more so than the other patients. It was a small facility, so we didn't have any subspecialties. There wasn't any cardiology. We had a neurologist that came by once a week, and a gastroenterologist that maybe came by once a month. But for the most part, anything inside the hospital was managed by us. Left there, came back to Florida, took a year off, traveled, and then came back and then went to fellowship. And from there, ended up in Missouri. And then after Missouri, came to Virginia, and I've been here ever since.
How does osteopathic medicine differ from a MD degree as a DO?
Essentially, they're the same. The only difference is in osteopathy, you learn manipulation, or basically looking at other portions of the body to kind of help with your diagnostic skills. Essentially, it was started by a doctor, A.T. Still, back in the Civil War era. He was not pleased with the way medicine was being practiced and felt there would be much to learn from looking at the body from different aspects, from the skeletal structure to the interactions between different fascial planes or portions of the body and how they interacted with the organs. And based on your exam or manipulation of those areas, you could actually help it heal. And so he created his own school. And MSU is one of the few schools that actually has three medical schools in one. So my classes are taken alongside MD students. So they have an allopathic, which is the MD school, the osteopathic, which is the school I went to, and then the third school is a veterinary school. Obviously, I don't take classes with them, but it has three medical schools in one. And then from there, I share my first 2 years of school with the allopathic students. So we essentially the same, except for I take an extra class in osteopathic medicine, which is mostly manipulation. The closest way I can describe it, it's similar to what chiropractors do, but the chiropractic angle is only one portion of it. We call that high velocity, low amplitude. And that is one thing we're trained in, but it's obviously not as applicable in the setting that I have. But I do use those skills to kind of help hone what I'm doing and to help me take care of my patients.
So I was going to ask, because you're in a critical care unit, so you're in critical ICU, more medical based, or how are you able to combine your skills with your training and manipulation with some of these patients?
So manipulation, it's oftentimes difficult in the medical only because we have quite a few other contraptions in the room. So like the ventilators, in some cases you may have to put in a dialysis catheter or a dialysis machine. So interacting with the body when it's that sick, it's manipulation was not meant in that entity. However, when I was internal medicine and I had my office practice as well as in the hospital, I use it a bit more then. So critical care, it is not as applicable. But then again, back in the Civil War era, they didn't foresee obviously using it in that degree. So it is limited where I practice now.
And what are some of the patients, a typical day at the hospital like for you?
Um, a typical day, depending on the season. So this year is what we call the MICU season, so the medical ICU. So our bread and butter are the busiest times are typically pneumonias, sepsis, COPD exacerbation, asthma exacerbation. Oftentimes you'll have some hyperthermia issues. We have problems with diabetics that come in. There are some trauma. We are a level two trauma, so we do see trauma patients. Oftentimes we help to take care of those patients in teamwork with the trauma surgeons. We have cardiac arrest patients. We have patients that have heart attacks that have to undergo stenting. We have stroke patients. So, bread and butter mostly is going to be your pulmonary issues. So, pneumonia, COPD, asthma, and sepsis are going to be the big hitters for us now.
And for anyone who's listening, if their loved one has had pneumonia or COPD, cardiopulmonary issues or complications, All County Healthcare, located here in Florida, helps with your post-surgical, post-medical needs. So when you're in ICU, CICU, what are some of the treatments that you're doing with your patients? So when they're discharged, that they're going to follow up on? Is it percussing? Is it oxygen treatment? Is it respiratory therapy?
Um, so depending on the severity, so if you're sick enough to make it into the ICU, it is pretty good chance that you're going to need some type of oxygen when you're discharged ultimately from the hospital. In some circumstances, people are able to get by with just a simple nasal cannula. Maybe I just have to institute probably steroids or some inhalers or bronchodilators. But in the really extreme circumstances, I've had to use ventilators. And so once I've had someone on a ventilator, that really changes the lung mechanics and just kind of how people breathe. And having to have those muscles regain some type of strength or endurance to kind of keep it up once the ventilator is removed from the equation, and then dealing with the long-term effects of the sepsis, the pneumonia, and the baseline COPD. So with COPD, again, I'm not a pulmonologist, but the I see it often enough to where I'm fairly proficient in how it progresses. So it's progresses what we call a stepwise fashion. So essentially, you'll have a baseline where you have a level of function. Once you have a flare up of your COPD, that level of function decreases and then it becomes a whole new normal. And then the key is to try to maintain that level of normal without having another exacerbation or another flare. Once you have another flare up, your then level of progression will decrease even more so, and you have that new plateau. So it becomes a new normal. So depending on where you are on that stepwise fashion and you encounter my ICU, coming out of it, you're going to have to be accustomed to a new normal, especially in the context of COPD. And so oxygen, some physiotherapy, or some PT is going to need to be involved because your breathing is not going to be the same.
Have you seen an uptick in cardiac issues or pulmonary issues with long COVID?
Long COVID, not as much in our setting. I know it's a more, I've heard it mentioned more so in the office base.
Okay.
However, in our setting, we don't see it as frequent inside the ICU. Again, to make it into ICU, it's pretty severe.
And you do hunting accidents, which you told me, which was really interesting. Things that you don't hear a whole lot about down here in South Florida. Car accidents, cardiac arrests, but hunting. What type of accidents are you seeing and that you're needing to take care of?
It's usually people just not adhering to, you know, good protocol or etiquette when it comes to hunting. So oftentimes, Virginia around the fall season and some portion of the winter, it's a big hunting area. So one of the ways that people like to hunt is setting up what we call a tree stand. So essentially, you find a lone tree, put up some type of apparatus, and sit in it long enough to wait for deer or whatever you're hunting to kind of come by. And if it's not secured properly, you could fall. Sometimes people don't necessarily stay sober, and so they may have accidents. A lot of it's falls, not oftentimes any shooting, but there are usually portions of it where it's just not being safe in what you're doing or practicing good etiquette, and you get hurt in the process. Rarely do you ever see of anyone getting shot accidentally or stabbed accidentally.
Every community is so different when you hear about the different things and what different hospitals are based on, because you're our level 2 trauma center. So you get a lot
Yes.
of the cases, but they first have to go through the ER and surgery and all medical treatments before they ultimately get to you. They have triage first.
They do, but there are some that get fast tracked to us. So um, obviously, COPD wouldn't necessarily involve surgery, but if they're severe enough in the ER, they do intubate and place them on ventilator in the ER, which would come directly to us.
Fast track to you. All right, if you can hold
Yeah.
that thought for a minute, we're going to take a quick
Sure.
commercial break. When we come back, we got more to talk about with Dr. Ayinde Bourne, all the way from Virginia. We're sponsored by All County Home Healthcare. Give us a call at 954-717-7027 for all of your Medicare and private duty healthcare needs. More to come, and we'll be right back.
All County Healthcare has exciting news for any and all patients with COPD or other respiratory ailments. Listen to what renowned pulmonologist Dr. Keith Robinson has to say.
Hello, I'm Dr. Keith Robinson, board-certified pulmonologist, medical director at Fusion Health Pulmonary Rehabilitation, and a board member with the American Lung Association of South Florida. We have exciting news for patients with COPD. We now offer IPV therapy at home, which has been demonstrated to improve airway clearance, decrease hospitalization, and improve quality of life of patients with COPD. Please call All County Healthcare for more information about this FDA-approved therapy.
For further information, call All County Healthcare now at 954-717-7027. That is 954-717-7027, or visit our website at allcountyhealthcare.com. You can also find us on Facebook, YouTube, Twitter, Instagram, and LinkedIn. Remember, All County Healthcare always puts the patient's needs first. You are listening to You and Your Doctor, Living Longer and Healthier, an informative show that helps you find answers to questions you always wanted to ask, but did not have that somebody that could make a difference in your life. Call into the show if you have a question at 888-565-1470, and we will put you on the air to inform all our listeners. Now, back to our show.
And welcome back to You and Your Doctor, sponsored by All County Healthcare, Medicare Certified Home Healthcare Agency. For more information to receive services in the Tri-County area, you can contact Clayton or anyone at All County Healthcare at 754-717-7027. You're listening to us on True Oldies Florida or watching us somewhere on your streaming platform. We have the pleasure of interviewing Dr. Ayinde Bourne today, all the way from Virginia. He is a critical care physician, doctor of osteopathic medicine. So welcome back, Dr. Bourne. Thank you again for taking the time to be with us.
And you're welcome.
Now, we were talking about things that you're managing in intensive care and CICU. What about diabetic complications? You had mentioned you're seeing quite a bit of that as well.
Most of the complication that will end up in the ICU directly is usually what we call diabetic ketoacidosis. Usually there's some type of illness or possibly some delay in getting the appropriate amount of insulin, and sugars run high, and the body kind of goes into this fat metabolism state. And unfortunately, one of the byproducts of that fat breakdown is an acid that builds up in the system, and it causes a lot of downstream effects: nausea, vomiting. People urinate a lot, and they come in supremely dehydrated and really acidotic. So it's trying to get them through that crisis early. If it's not achieved quickly enough, you could die.
One of my very good friends had diabetic ketoacidosis in ICU down here in Florida for, 10 good days. And it was scary there for a long time.
It is.
And then you have to go into management. What is the step-down unit once they leave where you are? Do they step down into regular care units, regular hospital beds, or directly to home? SNFs? What is typical?
It's depending on the how severe. So essentially, every floor in the hospital, the breakdown or the differences is essentially the capabilities of the support staff, so mostly the nurses, and what you're looking at from ICU and all the way down, it's the ratio of patients to nurses. So in the ICU, you have the highest ratio, so usually 2 patients to 1 nurse. The step-down unit kind of goes maybe 3 to 4 to a nurse, and then from there, as your acuity gets lower and lower, the amount of nurses to patient ratio increases. And so if somebody comes in, let's say, for example, DKA, and it's usually if it's somebody who's had DKA quite frequently or they're accustomed to it, and they're fairly young, they can bounce back pretty quickly. And oftentimes, I don't necessarily need to send them directly to a step-down unit. They can go to a general floor, and then from there, probably go home. If it's somebody who's went into DKA because of, let's say, a really bad pneumonia, let's say they got the flu. And so not only am I dealing with the DKA, but you also have to give time for the flu itself to resolve. And so those patients may need a little bit more closer monitoring, a little bit more hand holding. And so step down would be more appropriate, but it can run anywhere. A lot of it is dependent on the situation.
And your critical care, your care coordination, you've got the staff that's supporting you. Is there typically someone that's working, a social worker or a coordinator of care once they leave where you're at for the patients
Yes.
who get discharged to home at some point?
Yes. So since I've been in inpatient medicine, I know the paradigm has been to go more so with what we call a multidisciplinary approach. And so when I was a hospitalist, typically twice a week, I would meet with a nurse. There would be a nurse that would represent, or the charge nurse who would represent the nursing staff. There would be a social worker, there would be a case manager, and potentially even the chaplain or in physical therapy. But we would gather in a room and we'd go over each patient case by case and discuss, barriers to care, things to look forward to, or to try to anticipate that they're going to need a discharge needs. Being in the ICU, we have at my facility, we meet essentially every day. We sit down with the charge nurse at the beginning of the shift. We go over what's the plan for each patient. The case managers and social workers are actually involved right from the minute they get in, and we try to start to anticipate needs. So my role in that team is I essentially tell them what the medical plan is and how the patient's progressing. And then I also try to help discuss with the patient and as well as their family to figure out what are their capabilities at home. So if I anticipate, let's say, for example, someone with COPD and they're going to likely need oxygen, I try to gauge from the family as well as the patient, well, what exactly are going to be the needs? If this is the first time with oxygen being involved, maybe I need to let case management know to kind of reach out to the family and kind of make arrangements for deliveries. If this somebody's going to need physical therapy, what are the capabilities at the home? Are they going to be able to get around? Is there going to be facilities that allow them to use a walker? Do they need a cane? Again, physical therapy works hand in hand with me. They want to know when it's okay for me to get the patient up and moving so they can do their assessment. And so we try to start the whole process of transitioning outside of the hospital from the minute you actually hit the ER. And then there we try to put stuff in place and kind of have an ongoing communication. So if it ends up going to a SNF, the case managers as well as the social workers are well aware of that long before we get to that last few days. And we try to have open communications with the family members as well as the patients to kind of gauge from them what exactly do they need or what they want or prefer when it comes to that.
Have you seen the quality of the multidisciplinary approach better for the patient
Yes.
versus as things
Um,
have changed?
yes, I see it's actually helpful. It started mostly when I was in residency. I started seeing that more so, and then as I've gone more into my career, I've seen more people get involved. And just kind of what I've picked up from my career time is that I try to start doing that kind of planning, or I always have an eye towards down the line what my patient is going to need or how to get things in place. And so I try to gauge that. And we've just recently become a teaching facility, so we have residents, and I try to pass that along to residents as well. So I try to anticipate and put things in place ahead of time so that way I know when it comes time for the patient to go, it's not like the stop start. It's a more smooth transition, and everyone has ample time to be able to prepare for making that a soft landing. And as far as CMS guidelines go, like no hospital is going to want to have readmissions. And so we try to work as hard as we can to try to work with our resources in the community. We try to work with our case managers. We try to work with social work to try to make sure everything is in place. That way, it's a softer landing. The patient kind of gets an easy transition into their outpatient care and all the other places there. So, be it home health aid, be it inpatient rehab, be it outpatient rehab, whatever is needed is already put in place and set so that the patient can hit the ground running.
And bringing the family member in really helps with the communication so they know what to expect. And by putting everything together with the case manager, they can prepare themselves for when they go home or the next step down level for their family.
Yes.
Thank you so much, Dr. Ayinde. I appreciate your time taking it with us, talking about critical care and the complications that you see, and then what it's like to transition and titrate back into real life settings.
Well, I appreciate it. Thank you for having me.
Thank you. Pleasure to have you.
Okay.
And as we talked about all county healthcare, as Dr. Ayinde Bourne said, it's when you get home that's the next step. So whether you're anywhere in the Tri-County area in South Florida, your loved one is moving from critical care unit, from cardiac unit to hospital bed, they need some help in mobility, they need some help in just moving around, even daily needs. All County can help you with everything you need: COPD, pulmonary treatment, home health care aids, Medicare, and private duty. So give them a call, contact them. You can call Clayton or anyone at All County Healthcare at 954-717-7027. They are a Medicare certified home health care company. So thank you so much for tuning in. I am Dawn Graubert. Hopefully Luis Gomez will be back next week, and we'll see you then. Have a great night, everyone.